Good afternoon, all. Today at Aster CMI, we are in the Facebook Live and we have the topic of cervical cancer. Myself, Dr. Aisha, I am a specialist in obstetrics and gynecology. I have with me Dr. Chetna, who is senior consultant in obstetrics and gynecology, and Dr. Soumya Lakshmi, who is consultant in obstetrics and gynecology. So, we will be discussing about the topic of cervical cancer today. So cervix, a lot of people have this question, what the cervix is. Some people come to us saying that they have cancer in the uterus, but we find it in the cervix. Cervix is different from the uterus, but it is a part of the uterus. It is a lowermost part of the uterus where it attaches itself to the vagina. So there are two parts in the cervix. One part is attached to the vagina, which is called as ectocervix, and one part is inside the uterus itself. It is called as endocervix. So what is the importance is that these two parts have different kind of lining inside its canal. So there is a junction between these two linings which is prone for the cancer. So this zone is called as transformation zone, and this is what we take as a sample and screen for the cervical cancer. So many of us are prone to the cervical cancer, but we'll have to know about the risk population who are more prone for this cancer, like the patients who are already HIV positive, the people who are having sexual intercourse before the age of 18 years, those who have had early pregnancy, those who have had more than 3 of children, and those who have been exposed to a virus which is called as human papillomavirus. So, and those ladies who smoke. So, we will be discussing these things in detail today. So, I'll be getting back with the questions to our consultants. Ma'am, how common is this cervical cancer?
Yeah. Globally, cervical cancer is the fourth most common cancers in women. And in India, it is the second most common cancer, next only to breast cancer. It is the leading cause of cancer deaths in women in India. It is about 6 to 29% of it, depending on the area and district wise.
So, okay, ma'am, is it true that the incidence of this cancer is decreasing? If it is, then can you tell us the reason about it?
Well, it is decreasing in the sense that maybe a decade or 15 years back, cervical cancer was the most common cancer among women. Of course, now breast cancer has come, and then there are reasons for it. The first is the demographic changes. Like you said, cervical cancer is more common with early onset of sexual intercourse, more children, and so now we know that a lot of women are opting to have lesser children. They get married later. Of course, I don't think there's too much of a difference in the age of first sexual intercourse, but at least young people who indulge in coitus are using barriers. And like you said, human papillomavirus is one of the most is the causative agent of cervical cancer, and herpes virus and chlamydia are supposed to be the cofactors on which human papillomavirus enters our body. So when you use barriers like condoms and diaphragms, you can actually decrease sexual transmitted diseases and indirectly decrease infection with human papillomavirus. So demography, the changes that we have in our lifestyle is one of the reasons. The other reasons are most of the countries are now, they're inculcating standard screening programs. Because there is invasive cervical cancer is a completely preventable disease, and it actually has a long pre-invasive stage which can be picked up by these screening methods, and so treatment of these early pre-invasive pathologies are very effective. So we can actually prevent a woman from developing cervical cancer per se.
Ma'am, can you tell something about the human papilloma virus?
Yes. Human papillomavirus is the most common viral infection of the reproductive tract in women. So this virus is usually acquired at the onset of sexual activity. So, like Dr. Soumya said, majority of these infections are mild and they do not cause disease or symptoms, uh, and they resolve spontaneously. But there are about 150 types of human papilloma virus, and among these, about 12 to 13 are high risk papilloma virus, and they cause disease in humans. Among these, the commonest are 16 and 18, which cause invasive cervical cancer. About 70% of invasive cervical cancers are caused by the 16 and 18 papilloma virus. So here there is, it takes about 10 years from the onset of infection to the invasive stage of the cervical cancer to occur.
Okay. Ma'am, then how can we screen for this cervical cancer?
So screening is one of the most important to prevent cervical cancer. As Dr. Soumya said, cervical cancer is the most satisfactorily or successfully treatable cancers in women if it is detected early. So we have other screening options. The first being the conventional pap smear, which was done from time immemorial. Next, we have the newer ones, the liquid-based and the automated pap. The liquid-based and the automated pap are on the costlier side. Next, we have the high-risk human papilloma virus screening method. This is definitely costly, as well as it needs sophisticated lab infrastructure as well as trained lab personnel. Then we have the visual-based technologies. So screening has to start with the at the age of 21, and it is regularly done at 3-year interval. That is what is recommended. In after 29 years, 21 to 21, we do every 3 years. After 30, from 30 to 65 years, it is recommended a 3 to 5 year gap if it is co-tested with high-risk human papillomavirus, pap smear with high-risk human papillomavirus screening. So screening is irrespective of vaccine status in women. The yeah.
Ma'am, can I just ask you a question? You said we start at 21. So we have a lot of young women who come, they are not married. So would you still advise screening or?
No, if they are exposed, this is more efficacious if it is done before, when after their exposure to sexual activity.
So if they're not sexually active, we don't need the age is not a cut.
Yes, yes.
Okay. Ma'am, how do women with cervical cancer present?
Okay, so the most common presentation of women with cervical cancer is, abnormal vaginal bleed. So most commonly it is bleed just after, sexual intercourse, what we call a postcoital bleed, because, obviously the cervix is unhealthy, and anything that causes any, tactile stimulus on the cervix will cause it to bleed. So postcoital, but they can also come with intermenstrual bleed, or just irregular bleed. The other common symptoms are abnormal vaginal discharge, foul smelling vaginal discharge, and in advanced stages then it becomes will they come with pain, or inability to pass urine, or because it's already gone into the ureters. There are problems associated with kidney damage, but those are really advanced stages and rarely seen.
So how do we make the diagnosis of this cancer?
So the diagnosis is basically with a good clinical examination. So when the cervix, like Dr. Aisha already said, a part of the cervix is already in the vagina. So we have an instrument where, it's a speculum that will be inserted into the vagina, and when you open it, the mouth of the vagina kind of opens, and we can have a good look inside. And the only organ that really stares us at is the cervix. So when you see an obvious lesion on the cervix, you can just go in for a biopsy, take a small bit. It can be done in the OP procedure. It's absolutely painless. Takes about 2 minutes, and we send it for the lab. The problem comes when the cervix looks abnormal, but we have already done a screening pap smear, and the pap smear shows something abnormal. In those cases, what we really need to do is we have to have a high degree of suspicion. So we've seen a lot of people who have gone to the doctor, had a look, though the pap smear was abnormal, they have been treated with some antibiotics, and then they have come back, years or months later with a frank lesion. So whenever a pap smear shows some abnormality, even if the cervix looks abnormal, I think we should go for what we call a colposcopy. Now colposcopy is like a modified microscope. We can have a look at the cervix, and there are some red and light filters. Of course, it has to be done by trained person. But when you look at the cervix through the colposcope, you can see abnormal vasculature, irregular surface contouring, like the surface of the cervix looks abnormal, or sometimes you can see abnormality. There is a change in the color tone, and then it is very obvious that there is some problem. So you immediately do a biopsy, and we can send it. Because false negative for a pap smear test is about 50%. So if the patient is symptomatic, and even if the pap smear is normal, a biopsy should be done. But if the cervix is appears abnormal, but if the pap smear is again normal, or if the cervix appears normal, but the pap smear is abnormal, I think we should all have a very high degree of suspicion. Because like Dr. Chetna said, it's a very, very preventable cancer if you can get it early. So
it is said that if the human papillomavirus is positive, especially for genotype 16 and 18, but the pap smear is negative, the next option would be you go to colposcopy and directed biopsy, or you have an alternative to you do after 12 months you repeat the pap and
so basically we have to don't let the patient go, just keep her under close monitoring.
But if pap smear also is positive, HPV positive, then the next option is colposcopy and directed biopsy.
So what are the treatment options for this cancer?
So like all cancers, surgery is an option, but because the cervix is so near the cervix is located just right behind the bladder in front of the rectum, surgery is a viable option only in stage 1 or in stage 2A. I mean, so in layman's term, when the lesion is more than 2 centimeters, it is better not to go and handle the cervix surgically, because you can actually end up causing a lot more problems to the patient. Because chemoradiation, that is a combination of chemotherapy and radiation, actually can be used to treat all stages of cancer, and they are equally as efficacious as surgery in the early stages. But the only if I can just go ahead and just describe it in detail, surgery is actually preferable in younger women because there is an option of conserving the ovaries. So we don't really create a surgical menopause. Okay, so some people might argue that we can actually, remove the ovary from its place and transposition it somewhere, sometimes in the forearm, to preserve the ovaries and give radiation. But we have seen that over 5 years, almost 50% or even 60% of the ovaries just stop functioning when you transpose the ovaries. So surgery is an option for younger women or with people who want to preserve their ovaries and have very early stage disease. In later stage disease, we prefer chemoradiation because it is effective. Surgical treatment in later stages of cancer can cause a lot of other morbidity, like damage to the bladder, damage to the rectum, and then you have to have a colostomy because the rectum is damaged and you cannot pass motion so you have to have a colostomy bag and stuff like that. With radiation, you have other problems. Radiation can destroy your ovaries. It can cause a lot of inflammation in your intestines, and people with long-term radiation can actually come with, abdominal pain, bloating, diarrhea, episodes of diarrhea alternating with constipation. So basically, I think we have to see the patient, the age, what she wants out of life, how young she is, married, do they want to have any more children, the sexual history, all that has to be taken in account, and we have to tailor-make the treatment for the patient. I mean, individualize the care.
Dr. Samya, what about the pre-cancer, what we see in the pap smear?
So the pre-cancerous lesions, madam, so sometimes we can, they say very early, like CIN, like if you have pre-cancerous, like CIN1, if they have not completed their family, like you said, keep them on close observation. let them complete their family, and then we can go for a conization or what we call tracheography, because now tracheography can be done both laparoscopically, robotically, open, and we actually put a cervical encirclage, so to make sure that the mechanical, the cervix does not become weak mechanically, and these people can actually go ahead and have normal pregnancies and have deliveries too. So early pre-invasive stages, yes, we can still do conizations and preserve. We can also do laser, for the cervix. But yeah, but we don't see pre-cancer as lesions
We
very
get the
often.
pap smear report like sometimes
Yeah.
we get.
Yeah, so if it is very, very early pre-invasive and they have not completed the family, then I would suggest that we keep them on a close watch. And as soon as the family is completed, we can actually go ahead and do an hysterectomy, because it's actually waiting it's like a time bomb. Any time,
Yes,
it can become.
follow-up is very much
Yeah,
necessary.
Follow-up.
But this is not feasible or cannot happen in low developed areas and remote and rural areas where they say screen and treat.
Yes, screen and treat.
Screen them and treat them
Yes.
immediately, so
Because
that we don't lose them.
Ma'am, because in our setting, like the kind of people we get, most of them have started their cervical, they have annual health checks either from their company or their spouse's company, and most of them, even before their pregnancy, have had a couple of pap smears. The reason why, like you said, cervical cancer is still the second leading cause of death in India is because a lot of our population are from the rural areas who don't have too much, access to medical care. In those cases, instead of keeping them under long-term observation only to end up having to do a surgery for an invasive, I think, like you said, see, detect, and immediately, give a definitive treatment. Yeah.
So what is the 5-year survival rate of
The 5-year survival rate for any cancer, for that matter, is for a patient even after 5 years of the disease is alive, irrespective of recurrence of the disease or anything. And then this is from the start of the detection of the disease or the start of the treatment. This is around 60% or more in India for cervical cancer.
So, is it possible to prevent this cancer?
Yes, so more than 90% are caused by human papillomaviruses, that is what is said now. So we have the vaccine against the human papillomavirus. Right now we have 2 vaccines. One is quadrivalent vaccine, which prevents infection against 4 variants of the human papillomavirus, that is 16, 18, as well as 6 and 11. The other is the bivalent vaccine, which is against 16 and 18 variants of the human papillomavirus. Vaccine is most efficacious if it's given before the onset of sexual activity. So this is recommended, and it can be started at the age of 9 for girls. From here, from 9 to 14, it is recommended in a 2-dose regime with a gap of 6 months. And from 15 to 29 or 26 to 29 is what is said, it is given in the 3-dose schedule. So here we have this vaccine, which is a nano variant vaccine. It is against 9 variants of the human papillomavirus. This is a gender non-specific vaccine, and it is recommended, it is still in the license stage actually, and it is recommended to be given to boys as well as young men and the girls from the age of 9 to 45.
So, ma'am, how do we detect this cervical cancer and in pregnancy, and how do we treat in the pregnancy, ma'am, when the woman is pregnant?
Oh, thankfully, that is a very, very rare scenario, but it still occurs. So that is why I think we should get a pap smear done for all women. See, like I said, most of our patients who come to our clinic already had a couple of pap smears before they have become pregnant. But if we see somebody who've not yet had a pap smear, I think it is better to do it in the first trimester. Though a lot of our patients are a little skeptical because when you do a pap smear, it bleeds, and people don't like any kind of bleeding in pregnancy. But it is still, I think, something that we need to do because
it is done.
Pregnancy, yes, in Western countries,
pregnancy.
in the first trimester, just like a dental check, pap smear is a routine. But you know how it is in India. They don't even want us to do a transvaginal scan sometimes. So, but yes, a pap smear is recommended, and very rarely we do come across people who have cervical cancer concomitant with their pregnancy. If it's a pre-invasive condition, then we will keep the patient on close monitoring and allow her to continue her pregnancy, deliver, and then treat her. But if she has come with an invasive cervical cancer, then it will depend on what stage of pregnancy we have detected this. If thankfully, if everything goes well and we have detected it in the later stage of pregnancy, maybe after 28 weeks, then actually we can immediately deliver the baby, because after 28 weeks, the survival of the baby is more than 100, almost 100%, almost more than 80. Deliver and treat. The problem comes when we, detect it mid-term, because if it's very early, then we have no other option but to, terminate the pregnancy and then treat. Mid, then we actually have to sit down with, it has to be a multidisciplinary team. We sit down with the oncosurgeon, with the oncologist, with the pediatrician, and see, because invasive cancer kind of spreads very fast. So time is very crucial, is of essence there, and most of the time we actually kind of convince the patient to deliver and treat, because at the end of the day, the life of the mother is more important. Early cancers, after once you abort, again the treatment is the same. If it's uterus savering surgeries can be done, but in those cases prognosis is bad. But if it's a pre-invasive condition, then which we have detected very early, then even after abortion we can actually treat, and these women actually go on to have successful pregnancies and deliveries.
So, what are the chances of the pregnancy after the treatment of a cervical cancer?
So, invasive cervical cancer, the treatment is hysterectomy. So, it's very, very rare. It's absolutely not possible for the woman to conceive again, provided if her ovaries have been conserved. Then of course we can take her ovaries and then husband's sperm, and they can opt for surrogacy and have their own biological child. But natural conception, I think will not be possible. But in pre-invasive stages, like I said, we can actually give her uterus saving surgeries, and we can actually go on to have successful pregnancies.
How do we manage women with concurrent HIV infection?
Women living with HIV are more prone for carcinoma cervix than the general population. Here, the first primary screening method will be high-risk human papillomavirus vaccine. Human papillomavirus screening. So this has to start at the age of 25, and it is again regularly done. For every 3 years, they have to undergo this test. And the rest of it is the same. It depends. If it is positive, then you go for pap smear and then you continue. And for them, it is very important that you detect and treat as early as possible.
Okay. So I think we have summed up the cervical cancer very beautifully with both of our consultants. So
if anybody has any questions,
they can just drop in the questions. So I think we have come to end of our FP Live section. Thank you.
Thank you.
Thank you.